Hello, my name is Fatima Bawani and I'm a fourth-year medical student from Nova Southeastern University. So this is a case of very early onset inflammatory bowel disease in a 2-year-old male patient. So VEO-IBD is defined as IBD that's diagnosed before the age of 6. It's a rare but more increasingly recognized subset of pediatric IBD. It's characterized by its distinct genetic, immunological, and histopathological features. Patients often present with severe treatment-resistant diarrhea, as in the case of our patient, and they require early and aggressive intervention. Histologically, VEO-IBD can demonstrate features that overlap between Crohn's disease and ulcerative colitis, so this can make classification challenging. So this is something important to keep on your differential when you have patients who present with diarrhea since infancy. So for our patient, he was a 2-year-old male who presented with chronic diarrhea and significant weight loss, more than 5 kilograms over several months. He was born full term via elective C-section without NICU stay, and he was partially vaccinated. He had a history of persistent loose stool since birth, with episodes of bloody diarrhea noted in September 2024. He was initially treated in Cuba for assumed parasitic infections, but then had subsequent hospitalizations in February 2025. Upon arrival to the U.S., he continued to have episodes of 4 to 5 non-bloody diarrheas daily, also intermittent non-bloody, non-bilious emesis, and fever. His vitals upon admission, an important one to note from that is that his BMI-Z score was negative 2.64 SD, so all of the chronic inflammation was causing him to not absorb all his micronutrients, so he was significantly underweight. His review of systems was notable for fever, fatigue, pallor, vomiting, diarrhea, and a diaper rash. Again, on physical examination, he was awake, alert, but he did appear small for his age and had pallor. So we did a extensive workup on this patient. So for laboratory evaluations, we saw that his hemoglobin was 8.7, so this indicated microcytic anemia. His platelets were also low at 985, so this showed indicated thrombocytosis, which is associated with chronic inflammation. His stool studies showed fecal calprotectin was greater than 2,400, so this marked elevation is consistent with significant intestinal inflammation. His GI panel was positive for sapovirus and rotavirus. Abdominal ultrasound showed mild bowel thickening. On further imaging, we saw pancolitis and enteritis that involved the mid-colon through the terminal ileum. So this extensive GI inflammation that involved beyond the colon raised concern for the patient having this Crohn's-like phenotype of VEO-IBD. Colonoscopy also showed severe colitis, erythemus mucosa, shallow ulcerations all throughout the colon. And then biopsies from that colonoscopy again showed chronic inflammation throughout the GI tract. There was crypt distortion, cryptitis, and patchy inflammation and granuloma in the colon. The rectum showed ulcerative proctitis. The stomach and duodenum showed chronic gastritis, duodenitis with focal granulomas. The esophagus showed intraepithelial lymphocytosis. H. pylori was negative. And altogether, all of these findings and the clinical presentation of the patient supported this diagnosis of pan-gastrointestinal involvement due to chronic IBD that was consistent with our VEO-IBD diagnosis. So having this diagnosis in mind, we moved on to treatment, and consistent with the literature that biologics are beneficial for VEO-IBD patients, our patient responded really well to Remicade 10 milligrams per kilogram every 4 weeks. Corticosteroids were also given, which help bring down all of that inflammation. And then important for supportive care, he had a lot of nutritional rehabilitation that was essential to addressing his growth failure and all of the micronutrient deficiencies that he was experiencing. So overall, this case kind of highlights the importance of having this multidisciplinary approach, getting GI involved, immunology, nutrition, feeding therapy, and keeping VEO-IBD on your differential when you have patients who present with this very chronic treatment-resistant diarrhea. And this case overall kind of just illustrates the importance of, as incidents for these cases continue to rise, it's important to just have more research and collaboration with specialties when diagnosing and treating for these patients. So thank you so much and have a great day.